Afternoon, everyone, and welcome to our monthly Geri Echo webinar. My name is Sarah Tomkison, and I am a social worker on the Echo Hub team. I want to mention before introducing our team members that this webinar is being sponsored through the Queens Medical Center and Jabsom's Department of Geriatric Medicine. Joining me again this afternoon on our interdisciplinary geriatric echo team, we have Dr. Reese Oweno, our pharmacist. We also have joining us shortly will be Ms. Courtney Nunokawa, nurse practitioner, Susie Neufeld, physical therapist, and Dr. Lucas Morgan, psychologist. Housekeeping, I wanted to remind everyone about the evaluation forms. As a gentle reminder, if you would like to be able to receive your CMEs, you can find the evaluations by following the link in the chat or at any time on our website and email advertisement. We are currently offering continuing medical education for MDs, DOs, nurses, APRNs, and physician assistants. We are also offering social work CEUs and certificates of attendance for certified nurses, aides, and students. NASW's CEUs will be sent out monthly, and for the CME records, you will receive those by Queens Medical Center in mid-January of next year, which will be January 2025. I just want to let people know how important your comments and suggestions are to us in planning for future programs. A little bit about ECHO. We want to emphasize that the ECHO webinar serves as a forum for mutual teaching and learning from experts, and of course from each of us here on the front lines. As the ECHO motto goes, all teach, all learn. And in the spirit of aloha, we encourage you to turn on your cameras to help us build a community of learning. Please feel free to eat lunch during this session, for good nutrition is an important part of a healthy lifestyle. And lastly, I want to remind people that for HIPAA purposes, please remember to keep any information confidential. So if you have cases you want to share, please do not disclose the patient's name or birth dates, and your questions can be anonymous. This is a safe learning and sharing and no shame or blame. Before we begin the ECHO webinar, our format consists of a short lecture from our expert presenter, followed by comments from the expertise of each of the ECHO Hub team members. And you, the participants' comments, questions, and even examples of case discussions are welcome. We invite you to share any geriatric cases as well. So without further ado, is a pleasure for me to introduce to you today our speaker, Dorothy Colby, who will be speaking on the topic, It's All in Your Approach, Making Positive Connections, as she will address the positive approach to care. But a little bit of background about Dorothy, because she's too ashamed to talk about herself, but I'm not. She is a dementia care specialist. She has more than 25 years of professional and her own personal experience caring for people with dementia. She not only is a certified positive approach to care trainer, but she's the only national mentor trainer here in Hawaii. She's also affiliated with the Alzheimer's Disease Initiative Memory Care Navigator. She's taken training with the Dementia Friends as a master trainer and champion. And she's also certified with the Rosalind Carter Institute of Dealing with Dementia. She's currently the Director of Community Engagement at Haliku'ike. It's a residential dementia care facility, and there's 3 facilities she oversees with Nu'uanu, Kaneohe, and Pali. It is through her work at Haliku'ike and her public dementia education work that Dorothy helps those who work with care for people with dementia. She wants to impart that we understand that there are these brain changes that come with dementia. And by understanding these brain changes, we can empathize adjust our approach and even our expectations, and be more positive to be able to connect and communicate with those that are living with dementia. There's one last thing I wanted to let you all know is if you're familiar with the Hawaii Pacific Gerontological Society, Dorothy's being recognized this year as the 2024 awardee of the Dr. Tony Lenzer Scholarship fundraiser, and she'll be recognized in November. Thank you and welcome, Dorothy.
Oh my goodness, Sarah, thank you for that warm welcome and introduction. Let me get my screen share going. Oh my goodness, hold on just 1 second. We've got this set up right before and now it's, okay, here we go. Technical, here we go. All righty. All right, thumbs up, looks good, everybody? Everybody can see that? Okay, great. Thank you so much. I'm very excited to share with you on the topic of the positive approach to care, which is the national training and dementia education organization that I'm affiliated with, and that we use these training methods here at Hale Ku'ike and also in my public workshops, but more specifically about looking at how we can make positive personal connection for those people who are living with brain changes, whether it's Alzheimer's disease or any kind of neurodegenerative process that we're seeing changes. And so we'll be looking at the sensory processing system, looking at how someone who's living with brain change might interpret, visual input, auditory input, and sensory motor input differently, and then through understanding that, figure out how we can come together in a positive way. So, and there'll be a couple of specific approaches that I'll be sharing, which is the positive physical approach and then the hand under hand technique. But I wanted to start with thinking about why we do what we do, and for whom are we doing it for, and really focus on that relationship. So I know some of you a lot of you are at work and eating lunch, but no shame. I'm going to ask you to use your hands, and you can explain later afterwards why you're waving your hands around the computer. But if you take our two hands, our loving caring hand on one side is us, and then the person that we're supporting is the other hand. And we want to make sure we come together to form this relationship. So that's the most important thing before we get to our agenda of what we need to do, but coming together positively so that we can move forward together to a new and better place and a better outcome with less of this or less. So that's me pumping my fist together or trying to drag the person to this next space. So people who are living with dementia are really doing the best they can, and keeping that in mind, even when the best they can in that moment is downright terrible and possibly scary and all those things that we've experienced. But it really is doing the best they can with a changing and dying brain. And we are the ones to keep in mind who has the healthy brain in this relationship. I hope everybody's raising their hand. We are the ones that have the ability to change and make a difference. So when we think about the ways we as human beings, and when I say we, that's us and people who are living with brain change, take in data. We're all familiar with the basic five senses: what we see, what we hear, what we feel and touch, smell and taste. We're going to focus on the first three together today. So with what we see. So when we think about what we see, so if I put my thumb up and kind of look around like I'm an artist here, and you're taking in visual data right now, you're focused on the computer, but you have some peripheral awareness of people walking by or someone waving through my window here. I can see pretty widely. We as human beings, visual data is what we want first. This is our safety net, what we see. We want to see what's coming. If we hear something off to the side, what's the first thing we're going to do? Look, right? Like, oh, what was that? Something loud, right? If somebody touches us on the shoulder and we didn't know they were there, that's the third sensory input, touch. Oh, We're going to look. And once we see, we can calm down. Oh, it's you. Oh, it was just a car backfiring. I can relax. But we need to see. And when we're taken by surprise by those other senses, something loud, touch without seeing, we can uh, be a little, elicit that fight, fright, flight response. So when we're looking at two brains, the one on the left, the fat, juicy one, is a man, I think about 75, with no neurodegenerative process. He has a typical aging brain, died in a car accident. And the one on the right is a same man, about the same age. And notably, both these men have the same head circumference. So their skulls are the same size. Passed away after 10 years diagnosed with Alzheimer's disease. So when you look at those two brains, and the circled parts is the occipital lobe. If you touch the back of your head, the occipital lobe, where we process our vision, you'll notice some changes. And take a moment and think of course, you can type it in the chat or think to yourself, what kind of things are you seeing? Size, color, it's shrunken a lot. Cells are shrinking and dying. The blood flow in the brain is not so great anymore. That color, someone once told me, that looks like an old bruise. And it does. It's just not that bright color anymore. The spaces between the lobes there, it's there's a lot of gap. So we're losing matter overall. It's shrinking that way. So just go forward one slide here. There we go. So when we think about those changes, now these are visual processing changes. The one thing about Zoom is it actually does a really good job of giving you a kind of tunnel vision. So you're kind of tunnel vision looking at me. You're not aware of anything around me. And when we look at computers, it gives us a little bit tunnel vision here. But this edge of space, if you go like this with your hands, or if you put your hands straight out to the side and wiggle them, this is your peripheral vision. It's your safety vision that you get tested when you get a driver's license, right? They make you look in here. Do you see the light? Do you see the light? Because we need to have that awareness for safety. As we age, it gets a little narrower. So if you take your hands and make two L's like this and put them next to your face, like you're looking through the porthole of a ship, that's a pretty good simulation of about 75-year-old normal, typical aging individual. You lose a little peripheral awareness. So you might notice as you get older, now peripheral awareness is 360. You might trip a little more easily on steps and things because you just, oh, I didn't see it. I didn't see that route. Because it's just a little, and that's a normal change. But when dementia comes into the picture, and we see in those slides, there's actual brain matter loss. We go from this porthole for normal aging, make two C's with your hands, and make like you're wearing a snorkel mask or a scuba mask. And now look at your computer and notice what you don't see on the edges if you take it off and put it on. So my field of vision is getting, my field of active vision of what I'm able to process. And so it's not something wrong with my eyes. It's changes in my occipital lobe. I don't have the capacity to pay attention to what's on the side. And now make two O's with your hands like this, put them on for binocular. So this is where we're getting towards more mid stages of dementia. And so this binocular vision really is focused. Now notice the difference between the scuba and the binocular. My range is getting smaller and smaller. Now, if you're doing this and looking at your computer, I'm looking straight at my computer, can you see what's on your table down there? So if you wanted to see what's on your table, what would you need to do? Look down. Then if I want to see the computer again, look up. And so when I'm looking at my table, let's say my lunch, you might have lunch there. Can you see a possible table made across the way? Or you can't see it because you really get this focus. This is your task vision. When you look up to socialize, this is my social vision. What happened to my lunch? It's gone. But if I were sitting at a table with another person, let's say on the other side of this computer, whose lunch would I see? The other person. And I'm living with dementia. What I see is what I know. If I can't see it, I can't know it. So I reach and grab someone's food, and what happens? No, Dorothy, that's not yours. No. Oh my God, she does this all the time. Steals food, quote unquote, steals food. So sit her by herself because she can't, she can't be with other people. But we're going to take a step back and really look at that, what's labeled as a behavior or a challenging behavior, and think what's happening. What am I able to see or not? And then the last vision, make a monocle and cover the other eye or close the other eye. And that's end stage as we're getting closer to the end of the later stages, the end of life. I just can't process 2 eyes worth of data anymore. I'm going down to one. And you all know what happens when you wear an eye patch and you only have one eye, you lose your depth perception. And that really affects skill, mobility, all of those things. So these changes in how we're able to process vision make a big difference in how we're able to, me as a person living with dementia, move through the world and understand what's around me and understand what you are trying to tell me and what you are trying to show me. So it makes a big difference. And here's a little diagram. So you'll have these slides to refer back to here. So in addition to those changes in visual data, we said visual data is the most important. We want to get that first. Language data is something we're processing as well. And you all are watching me and listening to me, and I'm counting on you understanding 5 out of 5 words that I'm saying. But if you're looking at your phone or look away, step and come back, you miss one, you can pick it back up. But as people's temporal lobes are changing, so on the left hand, touching my left temporal lobe, you can touch your left temporal lobe. Higher language process is on the left. And that would be your vocabulary, in however many languages you've learned through your life, your comprehension, so auditory data is coming into your ear and you're able to understand what those words strung together in this specific way mean, your speech production. I'm able to take that vocabulary and put it back out in a way that you can understand. These 3 work together. When they start to falter, I can't find the words, I'm not putting them together in the right order, then we start to have trouble understanding each other. So you think I understand you. So I'm going to be you talking to a person living with dementia. Okay, you're going to say, Hannah? Yeah, yeah, you ready? We're going to take a shower now, right? Yeah. Sarah, we're going to take a shower now, right? Yeah, ready? Okay, she nodded yes. I'm like, okay, oh, here we go. She said yes. She got her name. She was looking down until she heard Sarah. And I was like, oh, Sarah? And here's this lady talking and nodding. And I can still keep the rhythm of speech. I understood that someone's asking a question, but I wasn't getting the content. So I'm not hard of hearing, although I might be for different reasons. I'm hard of comprehension. But on the right side, touch the right side of your brain here, your right temporal lobe. On this side, there's a number of gifts that allow us to get connected with auditory input. Rhythm is on the right. So things that are rhythmic, social chit chat. Hi, how are you? I'm fine, thank you. I don't have to think too hard to do that. Oh, your hair looks nice. Why, thank you. Yours does too. Just chit chat, superficial conversation. I can do that long into the disease, where I can't tell you what I had for lunch, or I can't answer an open-ended question, but I can do social chit chat. Music, poetry, and prayer. I might not be able to speak a sentence that's comprehensible, but if you play a song from my childhood or early, I'd say up to about 18 or 20, all the words come out. It's a different part of your brain. You don't have to think to remember, it's automatic. Prayer is a type of poetry. So someone who has a religious background, maybe knows the Lord's Prayer, you can start it, they can finish it. Rhythmic movements and autonomic movements. So, and everybody wants to go? Well, don't have to think. Put my hand out to shake your hand, automatically you put your hand out to shake your hand. Automatic autonomic movement. Those remain. And the last thing over there, forbidden words. So those very special words you say for very special occasions, swear words, all kinds of curses, sexual words, racial slurs, all those things that we learn, every single person knows them, we all heard them, even your sainted aunt who never sworn her whole life, knows the words, and we put them away on this side, and we have impulse control so we don't use them all the time. But when, remember the left side, all that higher language is lost. I have these forbidden words on this side, and something's happening I don't like and I don't understand. You know, you get the hell out of my, like, whoa, whoa, whoa. And words worse than that come out. Like, what? Oh my God, I can't believe my mother just cursed at me. Take a deep breath. I'm using the words I have left for the situation I have left. So, oh, I already mentioned this part here, which is I'm hearing you. So talking louder doesn't help me. Lower, slower. It's not just about hearing, although some people do have hearing impairment. It's about comprehension. So we love to talk. So visual, verbal, and then the last one, touch the back of your hand like this. Touch, touch. So if you do this, touch it nice and gently, soft. Oh, it feels good, right? We're hardwired. If it feels good, we keep doing it. If it feels bad, you don't hurt yourself, but we draw away, like, oh, that's hot. You don't even have to think, right? It's automatic. We lean into things that feels good. And one of the things that feels good, take your two palms, palm to palm pressure. Give yourself a hand massage. Feels great. It's comforting. Palm on joints, right? Feel that on your knee. Give your knees a little massage with your palm. Not your fingers like little spiders crawling on you, but your palm. So visual. We know that the field of vision is getting smaller and smaller, active vision. Verbal, we know that language processing is changing and that it's getting harder to understand complex sentences. And then touch. We know we want to get the visual, verbal before we touch, and we want the touch to be comforting. So that's where we come to. I'm going to show this one little video here. This is Lynn Moore, who's part of the PAC National people living with dementia team. And this is her talking about what it's like living with those vision changes.
That when I had heard from these vision changes, that the areas out around the scuba mask or the goggles would just sort of black out, and I would only see through the scuba mask or through the goggles. That isn't it at all. Right. The rest of that area is there. It's just that it takes too much effort to try to see it. Right. You have to concentrate the rest of your energy on trying to listen or trying to eat or trying to breathe or all the other skills that are still going on with your body, because it just everything takes too much energy. And so you can't use it.
So that idea of a person living with a changing brain is using all their faculties to really try and pay attention to what's going on in that area. And it's not that they're not seeing it, that it's just that the limit of the brain at that time is keeping things in the center there.
I thought.
So I want to share this positive physical approach. And the thing about this is, there's some, at the end, I'll share links to seeing longer webinars about this is a real recipe card that we use at Positive Approach to Care to help us remember to get connected visually first and then verbally in a positive way and getting permission to touch by using a handshake. And so I'm going to show you, this is the Holly Kwike staff practicing it. Hi, offering a hand, shake, coming into hand under hand there. So it's very, very simple. It's like, why do you need 9 or 11 steps to say hi to somebody and shake hands? But the formula of it is really to help us remember that order of visual, verbal, and only then touch, and slow us down and get permission to touch. Because in our fields, we're getting into touch, and we're getting into some very intimate touch, and coming in straight on, like, okay, here, I'm here to help you with your shirt. You ready? Like, whoa, 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 whoa. It can be very overwhelming. And as that previous video I showed too, I need time, I need space to process. Here's me with a resident, that's Holly Kwike.
Hi, how are you?
So starting getting connected this way before, maybe we need to get her up to go to the bathroom. Maybe we need to get some medication. But taking that time to build the relationship right there in that moment before we move on to the next step. I'm going to go forward a little bit here to the hand, hand under hand technique. So the last part that you saw in that video for the positive physical approach was getting into this hand under hand here. So my hand, the care partner, the supporting person is underneath, and the person who's living with brain change is on top. So I'm not, as opposed to the other way around, which is like arm wrestling the person, I'm here to help and support. And this comes down to, if you take your two hands here, these three fingers, these little, your thumb, your pointer, and your ring finger, these are your skill fingers, your fine motor. If you button a button, put on your glasses, you know, needle and thread, these are your skill fingers. With all dementias, skill is lost first, but strength, the other two fingers remain. So I've lost these skills, but together, both of our hands together, you have skill, I've lost skill. I can replace that skill in your hand and you can still be a part. Do you see here one of the PAC mentors helping someone take a drink that way? So the person, as opposed to putting the cup up to them. And here's Tipa Snow helping a lady in a care setting, eating chili. You can see her hand is under the other woman's hand.
That's good. Here you go.
I've never seen her open her mouth that big.
Yum. It's because her hand is coming to her mouth versus you poking her in the mouth with your spoon. And her brain going, whoa, what's that? Oh, wait a minute. Oh, okay.
Yeah.
Oh, it's okay. And this is like, oh, okay, I'm eating. Got it. That's pretty easy once I know what it is. Here you go.
Okay, I'll stop it right there. You might notice this lady when she's eating, where you notice her, she's doing with her eyes. She has them closed. So you and I can be in a noisy restaurant with our eyes open and eating and process all that data, although it does get overwhelming. But here she is, she's focused, she's in later stage dementia, focused on eating. Let's close our eyes and just focus on this one thing. I can't do two things at once. And I know for me, if I'm eating something really delicious and I want to have the full experience, have you done this? Like, you close your eyes. We do that. We close our eyes, turn off another sense. Or, you know, if you're in the car and it's getting complicated and traffic is going on, you're like, okay, I got to turn off the music or tell my family to be quiet because I'm concentrating. So when you have to concentrate, sometimes you need to turn down the other senses to focus on the one.
Good.
So I'm going to go forward here because I know we're getting the time here. Just to kind of go through, keeping in mind that people who are living with dementia are doing the best they can and trying out some different things, working to maybe the one thing would be thinking about, if you picture, and I tell Holly Clique staff, picture everybody wearing binoculars and think about, so let's say they're sitting like this or they're sitting like this. Where would you need to stand to be able to be seen? And just starting with that and coming in and make a big difference. So there's a lot more places you can go to learn more about these approaches and more details with a kind of quick overview. The Tipa Snow Positive Approach to Care website has free resources and also some for purchase resources. And then I've done a series with Catholic Charities from their Circle of Care for Dementia, and all the webinars, and it's not just me, there are other amazing speakers around the subject of dementia are there at Catholic Charities. And the Holly Clique website also has some webinars that we have on there as well. So those are all those resources are free, Catholic Charities and website. So that's my overview on the positive approach to care, and I would love to open up the feedback and questions. Thank you very much.
Okay, well, thanks so much, Dorothy, for giving us that little window into a very, very effective and powerful approach to a very challenging care situation. And so, yeah, like we usually do, I'll start it off by opening this up to our team, interdisciplinary team, and asking if folks have things to contribute, ask Sarah from sort of a social work perspective, thoughts on this resource, this approach, and anything else.
Yeah, I think what was really important, the emphasis that Dorothy made about relationship is so important as care partners, as healthcare providers. If we don't build that relationship, then it's key to getting that person to even not only trust us or rapport, but again, you can't really support anyone or help people living with these brain changes unless you can get their visual attention. That was the second thing that she emphasized, was the importance of making sure that, I know for me, sometimes as a social worker, I've got about 10 things to do that day, and I forget to take a step back because I'm really focused on the task and making sure that I see these other 2 clients and do the charting. And so I'll rush in, and I'm not really taking into account where that person is coming from, especially for that person who it may be later in the day. And so they're more confused. I noticed that they're disoriented. They're starting to seem a little irritable. So I think that's important. And she says, really make an effort to have that relationship, establish that. And you're going to establish it every time. Get their visual attention, which also includes, speaking first to that person before you even touch or do anything to the person. And I like that with this skill, she's really emphasizing the value of doing with the person living with dementia, because we tend, as care partners, again, it's really convenient for us to speak for the person or to do things to them as a nurse or whatever, because we're really pressured for time. And it's just more convenient to do it. But just seeing how effortlessly, after a period, seeing how Tipa Snow was able to accomplish getting this person that wasn't eating probably to use that technique called hand under hand to eat something. Even the aide or the nurse was just amazed that the person was feeding herself. And I don't know if people heard, but Tipa said, well, because you're not poking at, you're not poking her in her mouth. Her brain thinks that she's feeding herself, because we all kind of remember what that feels like sometimes when you're picking a spoon or fork. And Tipa was great by doing that hand under hand. She's kickstarting the brain, the client's brain, to remember that. So that's my take, is, again, relationship key, get the person's visual attention. That's the first thing you need to do as part of making a positive physical connection as a social.
Thank you, Sarah. Yeah, and it's in your role in social work, I think these helping families access these types of skill sets, I think, can be such a major difference in folks' lives. And so how do you think, or in your work, how is it right now in the reality of what's out there to get people in touch with this kind of skill set or training?
Yeah, I think for a lot of family caregivers, their intentions are very sincere, if they're caring for a family member or friend. And it's just sometimes needing that education piece for one, because we talk about having empathy, but it's pretty hard to feel empathetic when you're 24/7. There's no one to give you a break. It's only human to get frustrated. And your plate is full if you have multiple responsibilities, like you're working, you're taking care of your grandchildren, and to find that balance is really difficult. So I think, and you've done a lot of training for family caregivers, but I think to even get family caregivers interested, it's, again, we need to listen to what their needs are, and I think if we start even there with our family care partners, and what is it that's most important to them? What is it that matters to them in caring for this loved one? Then we can start introducing these resources, But as a psychologist, I'm I'm sure you get a lot of referrals
Mhm.
by family caregivers not being able to know how to cope with the situation, you know.
Yep, definitely. I'll share some of those thoughts in a little bit. And yeah, there's mental health and caregiving. I mean, there's just so much overlap uh, there, so much complexity. Thank you, Sarah. So Courtney, from a nursing perspective, how does this, these concepts and these resources kind of fit with the work you do?
I think to add on to Sarah, I think my initial kind of reaction is what a nice, like, humanistic approach to just add back in some human touch into nursing care. And really my thought as you're going through is like, wow, this can really, it's like every person can kind of integrate these strategies so that at different touch points, throughout the day, the person is getting this positive healing touch and interaction. And then I think I really like the hand-on for the feeding. That's a great, I want to share that with all the nursing students, because I think that, there's just so much going on there. There's the human touch, but also the motor integration, there's sensory perception. And then I really like the activity of kind of the progressive visual changes as the dementia progresses. I think that's a great activity to do with students so that they can kind of really apply how to like what's happening, how to make the connection from what you're reading in a textbook to how it really applies in life and affects people, but also families. And it was when you're talking about the food, a family actually came up to mind where the wife was like, we go to lunch and my husband just orders the same thing as me every single time, and I just want him to like pick his own meal. But I think there's comfort in kind of just saying like, I'll have what she's having, but I wonder how much of a visual component of now he's seeing what he's actually eating because he's mirroring. So thank you so much.
Thanks, Courtney. So yeah, there's a lot that can be integrated into anybody's role working with folks with dementia at any point in their days. So Reese, how about from a pharmacy perspective? Any thoughts or questions?
Well, I really enjoyed the presentation. I think Sarah did a great job of summarizing what they went over. But I just have a great awareness and understanding of people with dementia, especially with the goggles sample. And then I'll definitely use these skills at the pharmacy and in the clinic with patients, and just simple skills and having more compassion for the patients and the family members. But I really enjoyed it.
Thanks, Reese. And Susie, from a physical therapy perspective.
Well, I've been working with Hale Kuike for 16 years. Hi, Dorothy. When I first started going on site to Hale Kuike, I brand new in the world of dementia, and TIPA Snow was one of my first training modules that I learned on how to work with dementia. And I've been working in dementia and geriatric care for the last 16 years. And I have to say, TIPA Snow's method is still the method that I find the most useful. And it's also very, it's basic. It doesn't give you, it's basic on a level that non-healthcare professionals can understand. I use the visual approach all the time. I teach the therapists who work for me when I'm working with families. I can't stress the importance of really having that awareness of the visual field, how it does decrease, as the brain is dying. And to really be effective you have to get their visual attention. You have to stand in front of them, and again, I tell my families and my therapists, don't be on top of, like, they're only looking at your belly button. They have no idea who you are. You've got to get down to their level, look at them, in the eyes. So I can't stress the importance of, really having, if you're only going to take one thing away from this, it is that visual field changes. But also too, I think families do need to, they need to be, families and, and healthcare providers, they need to be flexible. Like here, this is a great example. I was actually at Halekuike yesterday working with a resident. She is in stage. The daughter still wants her to walk. Resident is having nothing to do with it. The daughter comes in every time when I'm there, and she wants her mom to walk. Yesterday, I mean, and it's just like, it's very apparent she doesn't want to walk. And so I approached her yesterday, and she just, she just got very like this. And I said, you know what? Let's just take her outside. And I just took her, we just wheeled her outside, and I just did the touching. We just did the touching. She calmed down, and I really educated the daughter on, we need to listen to these cues, and we need to be okay with what we have in mind. That's not what they might not need at that moment. So it's okay to adjust, and it's okay just to sit, and to now, and we just ended up doing gentle stretches with her, and she was very calm, and she actually became more verbal, during that time. And so I educated the daughter. I said, take advantage of that, like take advantage of her cues as well. So
Thank you, Susie. Yeah, really cool example. And I think you point to a really important thing, which is a lot of work with dementia is working with family members who come into the situation with, of course, their own histories, their own relationships with the person, their own emotions, their own fears of like, no, I don't want mom to stop walking. And so I'm going to fight tooth and nail, which contributes to the situation in often not so helpful ways. And so when you have some of these skills in your tool belt and you can demonstrate and show the effect on the person, that can go a long way to helping the family member maybe start looking at things in a slightly different way.
And it's also giving them basic information about what is happening to the brain. You don't have to be, you don't have to give them neuroanatomy, but that's what I really love about TIPA Snow. It's very simple information for a non-healthcare provider. And I think and that's our job. I look at that as my job, even as a physical therapist. I look at my job, like when I'm working with someone towards that end stage of, dementia, my job is to recognize, like, they're not going to walk anymore, or they're not even going to transfer anymore. And I need to be able to communicate that to the family so they can also prepare, like, okay, we're going through another stage, in this dementia process. And and I actually am very proud that I can, help a family member go through that and help educate them.
I was just going to add to what you're saying about the practicality of these tools, because a common, I guess, misperception that not just family members, I see this with staff, they forget that they do need to approach the person either from a supportive stance or from the side, right? Or to at least get into the field of vision to the front, or make sure that the patient or clients can see the field of vision. So the staff and the families often wonder, and they'll tell me, oh, so-and-so, Susie was so aggressive today. And I go, what? Well, I was behind her I was going to brush her hair. I started to brush her hair and she raised her hand like this. And I went, whoa, well, she probably didn't know you were there. She was startled. And the same thing when people, they're coming from the front and they just pop up. And like if they have binocular vision and they can only see 6 inches right below or front of them, again, I mean, I've made, yeah, she's laughing. That's right. I've made that mistake with patients, and someone grabbed my hand because she's in moderate stage. And I realized, oops, I made the mistake. I should have verbally give her fair warning I was going to approach her. So she used her little strength fingers and she pressed down. And then I had to relax, right? Because Susie, if I didn't relax, I just kept praying, look at her and say, look like you're sorry, Sarah. So I looked really sorry. And then I had to take my breath and say a second time, I shouldn't have done that. I'm sorry. Because I was just going to reach out to touch, but it was I moved too fast and I didn't get her permission. And so she reacted that way. And after about a minute or two, she actually let me go. She let me go, because what would you think would happen, guys, if I resisted and I started to pull? I think I would have torn. Yep. I would have gotten hurt, or she would have gotten hurt. So, and even though I know about these things, I'm still human. And I tend to push my agenda on people. Dorothy talks about this, people push my agenda because I forget that this is not about me. This is about the people we're taking care of. But I forget.
Yep, very easy to forget and very easy to be in our own agendas, like you said, whether it's professional, whether it's personal, and both often. So, you know, from a psychology perspective, I can't express how important skills trainings like these are, both for family and loved sort of family community member helpers and for professional helpers, in just changing the way that a person's life with dementia can go. Because depression is not necessarily a part of, you know, an inevitable part of dementia, and yet depression is pretty common in dementia. And most of the time, that's because the environment is conducive to depression. Isolation, confusion, agitation, conflict among folks that they're around, and also very common in caregivers. And so programs and trainings like this can go a huge way to changing the mindset of everybody involved, such that people feel more confident in what they're doing. People's mindset shifts for that increased empathy of like, wow, stepping into their world, and changing their approach accordingly can go a huge way to reducing depression and anxiety, reducing agitation and conflict, increasing quality of life. And, you know, that's really what we're going for here. And so I really appreciate Dorothy sharing this. And, you know, Mary Nell in the chat, and Capono also, you know, asking about what is the process, number one, of getting certified, but also what about availability of these resources? Is anyone like the state, you know, ramping up accessibility or funding? And this is a really tough question. I don't know, Dorothy, do you want to speak to those couple of questions?
Some of it. You know, in terms of the certifications, the one thing I like about the Positive Approach to Care, the company, is there's a lot of different options. There's full-on certification courses to become a trainer, to teach other people kind of the way I did today, and that's like a three-day hands-on training, and with a lot of pre-course work and post-course work. But there's also smaller nuggets that you could do. So Sarah and I together do, we call it a Positive Approach to Care Champion Day, which is taking what I shared today, but a full day of practice in different scenarios with each other, standing up, sitting down, helping someone brush, helping someone do little hands-on practice. We do those. Positive Approach to Care has them online as virtual courses for 2-hour courses. I believe each one is $50 if you're taking it as a standalone course. But we've been doing them here periodically. I think our next one is June 7th at Arcadia. It's professionals only, it's not public, and it's free. full day course. So that's kind of but again, and then the shorter ones, like it's not a certification, but what's available on Catholic Charities. This can be very helpful. It's Catholic Charities grants are targeting home unpaid family caregivers, but it's applicable. All these things are applicable to everyone, professionals and non-professionals. And I think somebody mentioned it's not just for approaching people living with dementia. It's people's brains are stressed for all kinds of reasons, including each other, coworkers. You walk in and like, oh, thank God you're here. You got to go down to room 5 because, oh my God, like, oh, I'm right in your face and I'm not giving you a chance to process what I'm saying. It's like, oh my God. So this kind of relationship forming can really be in terms of I see Susie's hand is up.
Oh, I was also just gonna
Yeah.
mention, I think Teepa Snow just has great resources on her website.
Yeah.
When Dorothy told me about Teepa Snow 16 years ago, I just went to her website, and her videos are very informative, very entertaining. She is an incredible teacher, and that's actually how I learned.
There's a lot of free stuff on her website, and she has a YouTube channel. I'm not on TikTok, but she's big on TikTok. There's a lot of and those are nice and short. I've seen a few of them. That's really kind of little bite-sized pieces there. So I always encourage people to just start small bites. So making one small change and go from there. But there are a number of organizations. Holly Kuike is a positive care designated organization, which means we have a lot of certified people here, and we're making a concerted effort to improve using these methods. But that's expanding. Kahala Nui is on that path. They're just starting. Hawaii Island Adult Daycare Program is on that path. There's a number of other organizations in Hawaii that are starting to adopt the positive approach care as their overall philosophy. So that's some progress too.
Thanks,
About opening the question about opening facility. There's a lot of things going on. I'm not so involved in that part, but there's a dementia roadmap out there, and there are things the state is working towards for improving family caregiver training, but I don't know the details on that.
The state of Hawaii received CDC Bold funds for a large initiative towards dementia education and training this coming year. Hopefully it'll be a 5-year grant that then will see a lot of information coming from the state trying to expand. I haven't heard about any further facilities though. Dorothy, we're getting a lot of questions about Acadia. I know before this you said that you only had 20 spots.
I only have 20 spots. Yeah.
Right. Yeah. And you're trying to prioritize the Acadia staff.
Yeah, so it's we usually have enough spots. So I think if anybody who's interested, if you could send me their email address, and I'll send them the information, if that's okay.
Yeah, I'll just, if anybody's interested, email me and I'll get you guys connected.
Yeah, it's a full day, so it's 8:30 to 3:30 all day with lunch. Yeah. And it is if a person was interested in getting one of the bigger certifications, there's trainer, coach, engagement leader, and consultant. This one-day course is one of the prerequisites for getting that. So you can take it as a standalone course, or you can put it towards getting the other certification too.
I think it's so great that these sort of larger and Arcadia and Kahalanui, of course, are sort of at the more higher end of sort of the affluent end of the spectrum for long-term care. And yet, if these organizations are adopting this as a standard, we can hope that there's going to be sort of an effect that ripples outwards across training for different levels of care too, all the way to the Foster Home Care Association. That'd be great to have it expand. I think for me, working in this field of caregiver training, what I've noticed about funding is that it's challenging, is that it is often very much grant based, especially if folks are trying to provide trainings at no cost or low cost. So I think it's going to be hard to expect like sort of the state to have some sort of permanent thing, but that the state and other folks really sort of champion these things, get it in sort of chunks, you know, and there's a grant that lasts a year or 2 years or 5 years, and then there's trainings that happen, and hopefully that continues to ripple outwards, you know. So appreciate all the hard work you're doing, Dorothy, to that.
Thank you.
End.
Thank you. The other resource that's out there, there's Japson, I can't remember what year it was, did the dysphagia video. It was filmed at Hollyquike Bayside, and Dr. Wen is on there, and there's a part of that where we do the hand in your hand assistance eating in that video as well. And so I don't have that link right now, but maybe that's something we can share it out later. That video is available in Chuukese and other languages, a number of different languages.
Yeah.
Because when Susie, when you're talking about helping families and helping them move, rather than in the journey to the next phase where someone's not going to be walking anymore, another one of those is person's not going to be eating the same way anymore or as much, and that's a big, that's a huge, hard road to acceptance on that sometimes, like that.
I think a lot of families just feel guilty, you know, that they feel that they feel like they're responsible and they own this, and it's just helping to work with them to see where that's coming from. Because we can do some more harm if you're force feeding people and you know they're choking and getting aspiration pneumonia, but and you and I have seen that. It's like, no, mom, you're gonna eat, this is your favorite food I made for you, and you're gonna eat it. Okay, you're eating the junk.
No, but I totally understand. And food is life, food is love, how we show love, and if we're not doing it, then like,
Okay, well, thanks everybody for. Oh, Dorothy, anything else?
No, that's it.
Really appreciate your time today with us, Dorothy, and giving us these really practical tidbits, and everybody wants more, and so hopefully you know folks will seek out these resources. Thanks for folks for attending and joining us as well during your noon hour. Be sure to fill out the evaluation form for obtaining CE credits, and really appreciate everyone being here and contributing. So hope you have a wonderful, and there's the
Thank you,
link
Lucas,
to the thing, and
Thanks for all you do, everybody.
Thanks, Dorothy.
Okay. Aloha, everybody.
Michaela, do we stay on at all, or do I?
You're good to get off now.
Good to go. Okay.
List of people interested.
And I can add them to my email list because Sarah and I will do more in the future too, not just this one on the 7th. So so that'll be great.
So if they miss this one, they can jump on to the next one.
Right. Yeah. Okay. Thanks.
Bye.
I'm glad Justin got to sit in.
I am too, and I need to send.
I think it's helping him formulate now more clearly how to tweak the presentation. And I did forget a couple. I forgot the first shaking the hand before doing the hand in your hand. So, but yeah,
it's nice to have the pictures for us too, right? We always trying to.
Right. I was telling my sister to get live clients or patients. Really, it's so much more meaningful because I mean, I appreciate your help, Ruthie, but you know how you're role playing or acting, you're acting the part of a patient. And with people that have these brain changes, it's really unpredictable. And I want people to know that sometimes when you want to do some of these, so you're not going to do hand under hand with someone that's an early stage dementia, because they'll probably punch you in the face like, what the heck, you putting your hand underneath my hand and guiding me to feed myself or taking me to walk somewhere. I can do it myself. Are you stupid or something? So, yeah, you wouldn't, but then we have to explain when you do these techniques. Because I remember when I first started learning this, I was trying to do it with someone that was like a SAF. We have these gem states, and the person was like still like in a diamond. They're very critical from a sapphire to a diamond. So they criticize